So good evening. Thank you for joining us for the first Adam Smith Society debate. In addition to the regular McCombs School of Business members, I wanted to give a special thank you to our members from the LBJ School of Public Policy, University of Texas Law School, the Social Sciences School, and also the Nursing School. Now, you've all seen the extensive bios on our two esteemed guests. We have Dr. William Sage on the right and Avik Roy on the left. I'm going to give you some highlights before we get into it, so please hold your applause to the end. So Dr. William Sage joined the University of Texas in 2006 and is now Vice Provost for Health Affairs at the James Dougherty Chair of Faculty Excellence in Law. He received his undergraduate degree from Harvard and his JD and MD from Stanford. He's an elected member of the Institute of Medicine, one of the national academies, which is considered one of the highest honors in the fields of health and medicine. Additionally, he has edited multiple books and written hundreds of articles pertaining to healthcare law and healthcare policy. Avik Roy is a senior fellow at the Manhattan Institute. In 2012, he served as a healthcare policy advisor to Mitt Romney, and this past December, he was named the opinion editor at Forbes. Mr. Roy also serves as principal author of The Apothecary, the influential Forbes blog on healthcare. Sorry?
He's a doctor.
Well, we talked about it.
It's all right.
What mistake did you just make?
Okay.
No, it's all right. It's fine.
No.
Okay, so
What did you do wrong?
we were talking about, so I was getting into it, but Avik Roy, so he graduated from high school in San Antonio, then he went to MIT and the Yale School of Medicine. So technically, we can call him doctor.
Technically?
Technically, but he said he didn't want to be called doctor.
Are you a doctor, sir?
Sort of.
Sort of. Do you have an MD?
No, technically no, because I didn't take step 2 of the USMLE,
No, but you didn't. Okay.
which is required at Yale to officially call yourself an MD.
Yes.
Not true at most medical schools.
Okay. Gotcha. Go ahead.
Okay, thank you.
It's all right.
So at the
We're just getting
Manhattan
warmed
Institute,
up for this debate. I can't abuse them if I don't abuse this guy, right?
so his research at the Manhattan Institute is focused on the Affordable Care Act, universal coverage, entitlement reform, international health systems, and FDA policy. Additionally, he's a columnist for the National Review Online, is a frequent guest on just about every television news program you can think of, and is an author of a new book, How Medicaid Fails the Poor. So please give our guests a round of applause.
All right.
And now we'll hand the floor back over to Professor John Dougherty, who will go through some rules and moderate tonight's event. Thank you.
All right. You know, for reasons, thank you very much, and I appreciate you being a teaching tool. You're a very good one. I don't know why they gave me a chair like this. It feels very, I don't want to sit here. It feels frightening. But we're going to have an intelligent debate about healthcare because we have two intelligent people sitting before you who know what they're talking about. And our goal is to do two things: to really dig as deeply as we can in the various issues on both sides of the healthcare debate, and also get you actively involved. And so the rules of engagement are very simple. Each one of these gentlemen are going to get 5 minutes to state their positions and what they like and dislike about the Affordable Care Act, why it makes sense or why it doesn't make sense, if it's constitutional, if it's not constitutional. And then I'll come up with some interesting questions, and we'll monitor the audience, and then when I get convinced that there are some people who are going to commit suicide if they can't ask a question, we will get to the question and answer period. And my goal is to have at least half of this discussion be Q&A from you guys, instead of the standard, which is we have 3 seconds left. Does anybody have a question? Sorry, we're out of time. So, who wants to go first? I like
Go first if you like. Whatever you want. What do you prefer?
Since you have
I'm the road team, so I guess in baseball that means I go first, right? Well, thanks everybody. Good evening. I used to live in San Antonio, as was mentioned earlier, and I graduated from high school there. And I haven't been to Austin actually since my senior year in high school, which was a couple of decades ago now. I have to say the traffic is even worse than what I remember, but I kind of like what the hipsters have done to the place. I had an artisanal antelope hot dog yesterday at Frank restaurant. It was pretty awesome. So thank you for that, whoever's responsible for that. I'd like to begin with a story, since we have 5 minutes, about a 7th grader from suburban Washington, D.C., named Diamante Driver. Diamante, in some ways, fits the stereotype of a poor black boy from the wrong side of the tracks. He, along with his brother Deshaun, were raised by a single parent, their mother Elise. Diamante was on welfare. He spent much of his time in and out of homeless shelters. He died in 2007 at the age of 12. But Diamante wasn't a victim of crime, drugs, gang violence. Instead, he died of a toothache. Diamante and his brother had never received routine dental attention, despite their efforts to seek it. When Diamante's toothache started, it took months of rejection and several dozen phone calls for his mother to get him an actual appointment with a dentist. The dentist they finally found told him that he had 6 abscessed teeth and recommended that he see a surgeon to get them taken out. It took another several months for his mother to find an appointment with an oral surgeon who was willing to do the job. 5 days after that surgical appointment was to have taken place, Diamante began to complain of a headache. It turns out that the infection from one of his abscessed teeth had spread to his brain. Soon after, he underwent emergency brain surgery. He got better for a while, but began to have seizures and was operated on again. Several weeks later, Diamante was dead. According to Ezra Klein, then of the Washington Post, Diamante Driver's story shows us why it would be immoral to repeal the Affordable Care Act, a law that strives to expand health insurance coverage to the uninsured. To repeal the bill, he said, without another solution for the Diamante drivers of the world, and to do it while barely mentioning them, we're a better country than that, or so I like to think. But Diamante Driver did not die because he was uninsured. Indeed, Diamante Driver died because he was insured by the government. You see, Diamante, it turns out, was on Medicaid, America's government-run health care program for the poor. Medicaid pays doctors on average about half of what private insurers pay. Most often, Medicaid pays less than what it actually costs to care for these patients. As a result, doctors are faced with the choice of caring for Medicaid patients and going bankrupt, or shutting their doors to the poor and focusing instead on those with private insurance. Surveys have found that internists are 8.5 times as likely to reject Medicaid patients altogether as compared to those with private insurance. Another study found that children on Medicaid with serious conditions, like uncontrolled asthma and broken forearms, had a 66% chance of being denied a doctor's appointment as compared to 11% for kids with private insurance, a 6 times difference, a 6-fold difference. Access to health insurance, it turns out, is not the same thing as access to health care, no matter how many times you hear otherwise. And it is for these reasons that study after study shows that patients on Medicaid have far worse health outcomes than those with private insurance. The largest study of this type, conducted by the University of Virginia in nearly 1 million patients, found that surgical patients on Medicaid were 97% more likely to die in the hospital than those with private insurance, and 13% more likely to die than those with no insurance at all. Another widely cited study, conducted in Oregon and published by the New England Journal of Medicine, was slightly more flattering to Medicaid. It found that Medicaid, and I quote, generated no significant improvement in measured physical health outcomes versus being uninsured. The so-called Patient Protection and Affordable Care Act does not protect patients like Diamante Driver, nor make their care more affordable, nor help them live longer. Instead of reforming the way we care for the poor, the law attempts to shove 16 million more people into Medicaid in its current dysfunctional form at a cost of nearly $100 billion a year, turning a public policy failure into a full-blown national crisis. In my initial 5 minutes, I don't have time to go through every single design flaw contained in this so-called Affordable Care Act, but I want to leave you with this. The American healthcare system is broken and does need far-reaching reform. But Obamacare doesn't reform our healthcare system. Instead, it doubles down on what's already bad and makes it worse.
Sir?
Oh, what fun. This is the third time that Avik and I have gotten to talk about healthcare, once last spring at Yale Medical School, once in December
Please share this with you.
Okay, you share
Socialism.
that with me. Yes, that's all right. You can see my terrible handwriting. Okay, a terrible disadvantage. It's hard enough to read my writing, but torn in half, it's almost impossible.
Sorry about that.
You
So
now have 4 minutes.
Nah, all good speakers know how to ignore time limits. So Avik's so we spoke at Yale, we spoke in San Antonio, and now here, and it's wonderful to talk with Avik about this because not only does he know a lot and is quite thoughtful about these matters, but he always surprises me with the examples. And so, it's very strategic to use the Diamante driver story here because this is a story that has been told many times from different parts of the left. And to hear it told from a part of the right is actually very, very interesting. So let's talk a little about Medicaid. And obviously, I haven't done the research that Avik's done, and I haven't written the book that Avik's written. So Medicaid is a state-administered, jointly federally and state-financed program that serves certain groups of poor Americans. Largely Americans who fit in the old classification of the deserving poor. Plus it has beyond kind of acute medical treatment a side that provides long-term care to people who need nursing homes well up into the middle classes because those are such expensive facilities to enter. Now the people who go get Medicaid, they may need services from a hospital, they may need services from a physician. And typically, when they need services from a hospital, they get Medicaid paid services from a hospital. But as Avik mentioned, that's not the case when they go to a physician or, for that matter, a dentist. And there's a basic rule of thirds. About a third of physicians accept all Medicaid patients who come in. About a third limit their Medicaid practices, and about a third do not accept Medicaid. So what's the big difference between doctors and hospitals with respect to Medicaid? What do doctors have that hospitals lack? It's a 4-letter word. Legs. Doctors have legs, and hospitals don't. And hospitals that have built themselves into neighborhoods would find it economically not viable to reject a source of government funding for patients they're likely to see anyway. Physicians have much more flexibility in how they organize their practice, where they locate their practice, and frankly, the signals they send to people who arrive for care, whether those patients are desirable to treat or not desirable to treat. So that's one interesting thing about Medicaid and the provider community. But let's now just fast forward a little to what I consider actually a very good rule of thumb for the future of our healthcare system and the business future of our healthcare system. So saying this to this audience is particularly useful. So if you talk to most hospitals or physicians today, and particularly if you talk to both together, and you'll hear, in many parts of the country, so we like taking care of private insurance because private insurance pays us a fair amount of money, pays us back for what it costs to care for patients. And Avik used that same phrase, what it costs to care for patients. And they'll tell you generally, Medicare is okay. Medicare, of course, is federally funded, federally administered program for the elderly, not Medicaid. Medicare is okay because, we can pretty much get by, and we hate Medicaid. Because Medicaid pays us so much less for taking care of patients than what it costs us to do. Okay. This is crap. What's the future of care, particularly at the hospital level, for our healthcare system? And you can verify this with hospital chief executives who are running real businesses. In the future, Medicare is profitable business. No private insurer is going to pay more than Medicare, and Medicaid damn well better be break even. So that's the goal. That's the goal for whatever we do in the healthcare system. We need to be able to deliver effective, available, reliable care at a price that the Medicaid program, representing a lot of poorer Americans and taking tax dollars from somewhat less poor Americans to fund it, can afford to pay. So Medicaid's actually a very good lodestar for how you should be thinking about the healthcare system. That's gotten through my 5 minutes, so I will skip the rest of this, even though it would probably only be 2 minutes more, and we'll talk about it in response to the next question about the ACA. But I like framing this around Medicaid.
Okay, so I'm confused by a couple of things. First was the term deserving poor, which suggests that there are poor people who are not deserving. So I'd like some clarification on that. And second, Avik said doctors are saying they can't make money. You say the doctors have legs and they run. And my experience, and way back when I practiced law, is the reason the hospitals deal with Medicaid patients is not just because they're not going to leave, but because most of the hospitals were constructed with federal grant money that said, if you take money from the federal government, you must provide care to people, period, even if they don't have the ability to pay. So let's start with the deserving poor issue, because that kind of got me.
Well, actually, if you don't mind, let me start with the second part, because it's just easier to address.
I'm sure it is, but
No,
let's start with the first part.
Well, both of them.
What does the word deserving poor mean?
Both of them date
And what is, give me an example of somebody who's not deserving and poor.
All right, so if you ask the state of Texas, someone who is not deserving of Medicaid and is poor is someone who is a childless adult or a parent who makes more than about $4,000 a year.
A year?
Yeah.
Okay.
If you ask Texas, if you ask Arkansas, I'm a little off on the numbers, but Avik
Well,
will
I'll
keep me in the
I'll just
ballpark
defend
there.
Dr. Sage here and say that 80 years ago, in the time of the New Deal, when welfare policy was in its infancy in America, there was often a distinction made between the deserving poor, that is, those who are disabled, those who who even through their best faith effort couldn't find jobs, couldn't gain employment, versus those who were able-bodied, could work, but were unemployed, and therefore
lazy
they were seen as
Deadbeats.
less deserving.
And both our cash assistance and our in-kind assistance through health insurance, through Medicaid, reflect these early social categories. One thing that we will agree on about the ACA and Medicaid is when the Medicaid expansion asserts roughly 133% of the federal poverty level as a uniform entitlement to Medicaid. So this is an individual who makes about $15,000 or less a year. A family makes about $25,000 or less a year. The ACA erases those distinctions and says not only on a state-by-state basis, but on a categorical basis, if you meet those income thresholds, then you are deserving of assistance regardless of whether 80 years ago we would have considered you deserving or not.
Okay,
So that's actually an important part of the act.
wonderful. Second question, we'll get back to the other one. What's the constitutional justification for ACA?
Oh, can I just get back to the other one briefly? Because there's probably people out there who are very curious about the obligations of healthcare providers. So the first obligations
Okay, I'll be nice.
the first obligations to serve the poor that you reference reflect the fact that you went to high school a little before me, and I went to high school a little before Avik. Those are Hill-Burton funds. They
Yep.
were conferred in 1946. Almost every hospital has fulfilled and outgrown its Hill-Burton obligations. I don't think there's a hospital in the country that still has an active Hill-Burton obligation.
But there is the EMTALA law.
No, and that you want to do that, you can do EMTALA.
I think EMTALA stands for the Emergency Management
Medical
Treatment and Labor
Labor.
Act of 1986, I believe it was, or maybe it was 1988. It was
86.
tail end of the Reagan years. It was, of course, Congress was Democratic then, but it was signed into law by Reagan, and it required that any hospital that takes Medicare money had to treat anyone in the emergency room regardless of their ability to pay or their immigration status. So it required illegal immigrants could be get free care through
Okay.
any hospital that took Medicare.
And that's still in effect.
That's
But
still in effect.
it is to screen someone for an emergency medical condition and to stabilize that condition if one is found, or to deliver a woman who is in active labor. It doesn't extend beyond that.
Okay? All right.
On the constitutional justification, well, I'm of the view that the law is unconstitutional. I thought that Justice Roberts made a catastrophic mistake from a jurisprudential standpoint, and leave the policy out of it. But I think we have since about 1937 not had a Supreme Court that adheres to the Constitution in terms of its text, its a strict understanding of its text. So we're far removed from that, unfortunately, and pretty much every federal law that's been passed by Congress since World War II violates the Constitution one way or another. So it's something I sadly tend, the grounds I tend not to fight on when I talk about Obamacare.
Okay. Sir?
The case, which, as you know, it's National Federation of Independent Business versus Sebelius as secretary, was decided in June of 2012, and it is widely recognized that the law was found unconstitutional in the arguments, but constitutional in the result. So the law survived, but all of the description of the law described the ways in which it constituted federal overreaching, and because it was federally overreaching, it was not simply contrary to the text and intent of the framers, but it was also, in the views of a surprising number of justices, a threat to individual liberty. I would have argued it on much more communal grounds, that this was a national problem that required a national solution, and that a combination of the spending power and the commerce power was sufficient to justify it as a matter of constitutional law.
I mean, it's really the Filburn case, which I think was decided in 1937, it may have been 1942, that in which the Supreme Court first declared that a man growing wheat on his own farm to feed his own animals was engaged in interstate commerce, thereby justifying federal regulation. And that precedent was upheld as recently as, I believe, 2006, when Justice Scalia supported the federal government's ability to intervene in the case of a California woman, Angel Rach, who was growing marijuana for her own use, because that somehow also had something to do with interstate commerce. So it's unfortunately, the Supreme Court's view of what interstate commerce is has been corrupted for a very long time, and Congress has followed their Supreme Court's lead.
I think this is less about commerce than about national problems and who solves them when the national problems are domestic, not limited to defense, and when the solution to the problem impacts things that all of us find quite personal.
Okay. If you're not a lawyer, I see the lawyers in the room are yawning on this, the Constitution has the 10th Amendment that says anything not specifically enumerated to the federal government is owned by the states. That's the easiest translation. And the Commerce Clause, Interstate Commerce Clause says if stuff is in interstate commerce, then the federal government has a right to be involved. And the two decisions you talked about said, well, if I grow weed or wheat and just use it, that affects interstate commerce because I'm not buying it from somebody else who might be in another state. And those of us who are concerned about that say, if you have that interpretation of the Interstate Commerce Clause, the 10th Amendment is meaningless because everything is interstate commerce. And what was interesting about the decision is they didn't use the Commerce Clause, they used the Taxing Clause to justify it. But let's move on. The big problem many people have about the conservative or Republican position on health care is based on simple data. Tens of millions of Americans do not have health care. The number one cause of people going bankrupt, according to some sources, is paying catastrophic health care costs. As defective as the Affordable Care Act may or may not be, what have the conservatives offered as a solution to a real problem for tens of millions of Americans? So we'll start with you, Avik, on this one.
An excellent question, and we could go on for days about the answer.
I like
but let me start with this: the studies that are cited to claim that that medical bankruptcies are the leading source of bankruptcy, that millions upon millions of people suffer from medical bankruptcies. Those studies are basically junk. And if you want to read more about why they're junk, I encourage you to read Megan McArdle at The Atlantic has written quite a bit about these studies, and I have as well.
You mean people have lied?
I would say the studies were authored by single-payer advocates, and they they tortured the data until it confessed.
Okay.
But
Tell us what the studies actually mean.
Well, they counted as somebody who. I'll summarize, but basically they defined as you went bankrupt because of a medical issue, anyone who had a medical issue when they went bankrupt, rather than people who actually had medical bills that made them bankrupt, which is not the same thing.
If I could
So-
stop you there to agree with you, I just want to reinforce that. So if the argument is that medical bills are the major cause of bankruptcy, Avik is correct. The studies do not compellingly demonstrate that. But if the issue is that when people suffer a major shock to their health, a combination of circumstances often results in bankruptcy, I think that's indisputable.
Right. Well, I was going to get to that. So,
Sorry.
I do think that, and I've written this many, many times, that in fact, I just had a piece in the Washington Examiner last weekend, in a cover story in the magazine, which is titled "The Conservative Case for Universal Coverage," and it claims, it proposes that addressing this problem, ensuring that no American goes bankrupt due to catastrophically large medical bills, is a legitimate goal of public policy. And here's the thing. What is it that you would go bankrupt from if you have catastrophic medical bills? Catastrophic medical situations. That is to say, we could protect every American from bankruptcy due to medical illness with a far different healthcare system than the one we have today, one that actually involved catastrophic insurance for catastrophic medical bills, not an insurance system that pays for your routine expenses, but one that actually, if you have a heart attack, you get hit by a bus, you have cancer, you get shot, that it covers the expenses incurred by those catastrophic expenditures. And if you did that, you'd have a system that spent a fraction of what we spend.
Go ahead.
But here's a time to reprise the Medicaid study in Oregon that Avik cited for other reasons. So this, if you are interested, really good empirics on health policy are hard to find, and Avik and I would agree that this study is really good empirics, and the results vary in their political implications. What this study is, it's an unusual natural experiment. The state of Oregon found enough money in a biannual budget to add families to its Medicaid rolls, but not to add all the families that met the eligibility requirements. And so they did something unusual in public policy, that a lottery. And researchers took advantage of the lottery and studied the people who were similarly situated, who enrolled in Medicaid because they won the lottery, and who made do without Medicaid because they lost the lottery. Not only looked at utilization characteristics, but actually looked at some underlying health characteristics, talking to people from both pools and measuring objective data. And what's interesting in terms of the effect of financial stress, so Avik is right when he said earlier that there were not, in the first reports that came out of this study, there were not demonstrable health benefits from having Medicaid. What there were demonstrable reductions in anxiety about finances. There's a lot
You could get puppies for that, too.
There's a lot of financial reassurance that came with not facing the risk of catastrophic loss. And what's catastrophic to someone on Medicaid is not what's catastrophic to us.
Yeah. So that's the thing. It's like, there's some people who say, well, this study was a success, the Oregon study, because it showed that people were protected from financial loss. But you can protect the Medicaid population from financial loss with a fraction of what Medicaid spends. And this is one of the reasons why expanding Medicaid is such a tragedy, is it consigns people to really poor health outcomes because their access to primary care and physician care is so poor, while not really addressing the catastrophic financial needs they have. Because again, because the Medicaid is so expensive, you can't apply it to more people. If we could take the money we spend today on Medicaid, and if we offered catastrophic coverage to everyone on Medicaid, we could literally cover everyone. Obamacare doesn't cover everyone. Obamacare leaves 30 million people uninsured even when it's fully implemented, assuming the websites get fixed and all that stuff. So there are other approaches, and I think that's very important. I think to a large degree, the debate about Obamacare is structured as, well, if you're against Obamacare, you're against protecting the poor from financial catastrophe. And that's absolutely not true. But to get back to your question, it is true that conservatives have largely neglected this area historically. And that, and there's a reason for that. And the reason is that if you think about who the typical Republican voter is, the typical Republican voter is either employed or retired. And employed and retired people benefit from about $1 trillion a year in healthcare subsidies in the United States. And so those are the people who are least likely to be motivated to feel that the system is problematic and harmful. So it requires Republican politicians who are willing to transcend their voter base and actually reach out to voters who don't vote for them in order to advocate healthcare reform that is truly in the national interest, including for the people who vote for them. They just don't necessarily realize it. That takes a kind of politician that we don't always see.
Well, let me put something out on the table briefly, and then we'll, I'm sure, come back to it in discussion. We seem to be falling into a discussion about health insurance and insurance. That is an impoverished conversation that will not help us deal with the really critical challenges in health reform, which are not, by the way, around insurance. You may have feelings about constitutional authority or the best use of public money that connect to insurance. Or on the other hand, you may have feelings about compassion, about the need for people who have medical conditions to access health care that they couldn't otherwise afford, that also connect for you to insurance. But these are actually easy things in policy terms. And the thing that's most worrisome to me about the current situation is that we continue to argue about these easy things. We have two very difficult things that are behind all of this. One is the way we deliver healthcare in this country is extraordinarily costly, wasteful, and often ineffective. We waste, in ballpark terms, $1 trillion a year on healthcare. And that's not because of Obamacare. And if it is because of government, it's because of decades of government with both parties bearing significant responsibility. Second is, we are not healthy. We've cut back on tobacco use by 80% in this country. That's wonderful. If we could cut back the other 20%, we'd do more for our health and longevity than any other single intervention I could think of. But apart from tobacco, we have had miserable successes dealing with all the things involving our lifestyles and behaviors and community design that cause us to acquire multiple chronic diseases and live less long and less well than our fathers and mothers did. And if you want the basic example, if you put up the CDC maps of the United States on obesity in adults, so this is obesity is kind of, as they define it, 30 pounds or more overweight for someone who's, say, 5'4" tall. So it's a fairly significant amount of additional weight. If you go back to the late 1980s when the first measurements were made, there was not a single state in this country that had as many as 15% of its adult population obese. Today, there is not a single state in this country that has fewer than 20% of its adult population obese, and there are several that have well over 30% of the adult population obese. So if we don't stop wasting $1 trillion, and if we don't get healthy, we are broke, sick, and ultimately dead sooner than we'd like to be. And that's where this conversation really needs to go.
So let's build on that. Let's go on the assumption that we have a lot of unhealthy behaviors. Two questions. One, is it the role of the federal government to make people stop eating, I don't want to belie any of our donors, but unhealthy food, A. And then two, you know, one of the things that caught my attention when we were debating the ACA was the head of Kaiser Permanente, and he said, the number one cost that's killing our system, and they're a big HMO, are people coming to emergency rooms who can't afford to pay, who have chronic illnesses like high blood pressure, diabetes, or asthma. So these are things that can be treated, and if we treated them, we could reduce our emergency room expenses by 80%, and if we did that, it would have a significant impact on reducing the cost of health care. And in Austin, a couple years ago, turned out that 5 homeless people went to our public hospital 1,500 times. The same people, but there was no system make people realize these are the same people. And the cost for these 5 people is over $5 million because they had no insurance. So clearly our current system is broken. And so my 2 questions are, what is the justification for the federal government getting involved in how people live their lives? And 2, was the ACA, Affordable Care Act, was it the best solution to a problem that the head of Kaiser Permanente says is much more basic, which is getting people to take care of their health?
Can I start with this? Because I want to offer you a deal for the rest of the talk, which you may or
Keep
may
your
not-
answer
you
under
may
1
not
minute.
That's
take.
the deal?
I'm a
Okay.
lawyer. As you know,
How much time do we got?
As they say, a picture's
Well, I
worth
like
a
that.
thousand. A picture's worth 1,000
He's
words,
gonna
but lawyers
offer-
prefer the
he's gonna
1,000
offer
words.
a deal, but if I don't buy the deal, there's no deal.
No, yeah, here's the deal. The deal has to do with your example, and I don't know if this was a George Halverson quote or exactly what the context was, but my deal for Avik is that we should not talk about emergency rooms for the rest of the time. It is a salient but misleading example in almost every connection that you'd use for health
Before
policy.
we have that deal on the table, since you're an expert in the subject, how big of a problem are emergency rooms for hospitals? Large, small, infinitesimal?
It will take us so far away from.
That's not my question. Is it a big issue for hospitals, yes or no? And if it's not, we move on.
Depends where you are. If you're located along a freeway where most of the people who come are insured, it's a great thing for a hospital economically. If you're located in an inner city where you're subject to a lot of violence involving people who can't pay you, it's a big challenge economically.
Okay.
Oh, I'm going to make one point about emergency rooms and then we can stop, which is that one thing that the Oregon study showed us very recently, and I wrote about this just a couple weeks ago, a new paper published in the journal Science from the Oregon authors found that when the people who got Medicaid in Oregon used the emergency room more than the people who didn't get Medicaid, and not for catastrophic illnesses, but for non-urgent medical care. And why is that? Because they can't get access to doctors. So instead of spending all day on the phone trying to get a doctor's appointment, they go to the emergency room, they know they get care right away. So if the argument is we're going to reduce emergency room utilization by expanding Medicaid, the data shows us that's not the case.
So a couple of lessons.
But no, now I'm going to answer the actual
Okay.
question that we were asked, which had to do with unhealthy behaviors. And I think both of you are trying to make me feel guilty about my antelope hot dogs. So
No, not at all.
I mean, I would be pretty sad if the federal government abolished antelope hot
How much
dogs,
did
just on the
artisanal?
record.
How much did it cost? That's my question.
$8.
You should be embarrassed about the $8, but not about the.
He's from New
Well,
York,
I'm
he
only in
doesn't know any
Austin
better.
once every 24 years, so. I think if we're going to be empirical, there is very little data to suggest that unhealthy behaviors are correlated to systemically high health expenditures. We all have to die of something eventually, and if you think about it this way, the longer we live, the more Medicare is spending on your existence. So actually, longer life expectancy leads to, in a sense, more consumption of the healthcare system. And if you look at the countries if you look at Europe and look at the countries in Europe that have the highest obesity rates and compare that, cross-reference that to their national health expenditures, you don't see any correlation. The UK has the highest rate of obesity in Europe, and it has one of the lowest rates of national health expenditures in Europe. Germany is another country with high obesity rates in Europe. It also has relatively lower national health expenditures. So, I mean, that's a very simplistic comparison, but there is a lot of talk, qualitative talk, about unhealthy behaviors leading to higher health costs. There's not a lot of empirical rigor around assertions of that nature. Again, we all have to die of something, and whatever we die of is probably going to cost money to treat. So I'm not that excited about fat taxes and their ability to reduce A, unhealthy behavior, and B, the cost of healthcare. If you look at Denmark, they passed a fat tax. They passed a tax on potato chips and junk food. It accomplished nothing. They repealed it 5 years later because they found it made no impact on behavior. So I think that whole, from a public policy standpoint, While I wouldn't recommend that people eat animal hot dogs on a daily basis, I don't think there's that big of a role for public policy on that front. It's more of a social mores issue than a public policy role. I think where there can be, I do think that the way we pay for healthcare does matter, because the biggest issue in the United States in terms of the healthcare system, the reason why the healthcare system is so messed up, is because of what hospitals charge to treat people, what doctors charge too. Doctors and hospitals are really rich in this country because of the way our system is all messed up. We would be better off with either a single-payer system or a free market system. What we have today is the worst of both worlds in many senses when it comes to the issue of affordability. And that's why the system costs so much. So I'm not a supporter of single-payer, don't get me wrong. I'm implacably opposed to it.
We were just getting ready to coach you on that.
But I would just say that one merit of single payer is that it would cost less than the system we have, and that's probably the only merit of it. But it is a merit worth acknowledging in an intellectually honest debate. But the way we pay for healthcare does matter, because if you don't have some mechanism to push back on what hospitals and doctors charge for their services, you have no mechanism. And hospitals and doctors charge whatever they want, and that leads to massive price inflation.
The federal government should push back on what doctors
I think that given what the federal government already does to distort the market for health care, there is a role for reforms at the federal level that would reduce the level of distortion that the federal government imposes on the market.
All right.
Okay, we're all agreeing on this one, though I'm going to disagree a little. We'll come back to the costs of unhealthful behaviors and the public policy tools at one's disposal to improve that situation. But the starting point, I think, is irrefutable. American healthcare costs have gone through the roof, and we can't afford them. And poor health in this country has exploded, and it's a bad thing. And I notice I didn't say we can't afford it. I said it's a bad thing. I think we can agree on that. As far as hospitals being grossly overpriced and physicians being at best enablers of hospital overpricing, at worst exploiters for their own interests, we can also agree. You've noticed perhaps the New York Times has done an expose of hospital pricing. Of course, if you take the New York Times to Rick Perry, he is very unlikely to read it and much more likely to use it for other purposes. I'm told the Wall Street Journal next month is doing its own coverage, extensive coverage of high healthcare costs. I am very much hoping that over the next year we will see pretty much the same story about high healthcare costs on NPR and on Fox News. And when that happens, maybe it will sink through. But we agree on this. This is a very, very serious issue that demands immediate attention. Where we would disagree is whether the ACA makes it easier or harder to address that. We'll keep going on this.
Let me just stop you there for
Well,
1 second and just say.
I'm going to stop both of you right now. 'Cause you guys are really good at debating each other, but I am sensing in the crowd some questions.
One sentence, which is to say, I wrote a 3,000-word
You go ahead.
essay for National Review on the topic. It's called An Arm and a Leg, and it's on this topic of how hospitals manipulate the system to overcharge for services
So
that are
let's now go to the
less
audience.
expensive.
Who has a really brilliant question? Stupid questions are not wanted. Brilliant question. Yes, sir.
Can you guys continue on how you lower those healthcare costs?
Thank you.
I will be seeing you outside after this.
We can also take a series of questions. if you want.
Here's what I would say. I'd say the way things work in the real economy, the non-healthcare economy. David Goldhill, a great writer on healthcare topics, calls healthcare the island, and the rest of the world, the rest of the industry, the mainland. And the way things work in the mainland is you shop for, say, a TV or a car, and you shop for yourself. If the car is too expensive, you don't buy it. You buy another car. And that is the price discipline. The price discipline is that if you, the supplier of the product or service, charge too much, the buyer of the service can go somewhere else, and eventually an equilibrium is reached, right? That's classical economics. That's not what happens in healthcare, because not only are you not paying directly for the product, because it's typically, most people aren't paying directly for the product because they have insurance, a so-called third-party payer. But most of us aren't directly shopping for the insurance plan. It's offered to us by the government or by our employer. So not only do we have third-party payment for healthcare services, we have third-party payment for the insurance product. So we really have ninth-payer healthcare in this country. And it's no surprise that in a system where you're 9 orders of magnitude removed from actually shopping for the healthcare service, you have no incentive to shop for value. It's like the difference between a cash bar and an open bar. At a cash bar, maybe you get, the Bud Light or whatever, or maybe here would be the Lone Star. No, it would be the Pearl, right? Pearl is the low-cost kind of crappy beer in Texas, right? That's what I remember anyway. But if it's an open bar, you're going for the artisanal, a microbrew beer or a single malt Scotch, right? And that is the economics of healthcare in this country. Is that because we don't have responsibility to pay for it ourselves, it's unsurprisingly expensive. And if you look at a country like Singapore, which has a model very similar to what I was describing, where you have catastrophic insurance for everyone, sponsored by the government, by the way, single-payer catastrophic insurance for everyone, and then health savings accounts that everyone uses to shop for routine care, which are taken out of your bank account through a payroll tax, like a Social Security tax, and then rerouted to you in a health savings account. They spend on health care 1/7 of what we spend. We would have a budget surplus, not a deficit, if we had the Singaporean system. And healthcare would be their life expectancy, their health outcomes are are meaningfully better than ours. They have access to the latest technology, access to the latest doctors. Now, that's not a libertarian utopia. There are a lot of elements to which the government is involved in the way healthcare is delivered. There's price controls in Singapore, for example. But the fact that people are shopping for their own care, particularly routine care, makes a big difference in driving down the cost. And that's a system we are far removed from.
And I think the other thing you should add to it is we don't know how much it actually costs for the services that we're getting, because we don't get bills that show the full amount that's being billed to the insurance company, so I guess that adds another third to your ninth.
Okay, so I think I have to do a little remediation here. So on Singapore, Avik did it himself, which is, I think it's fine to talk about Singapore, and there's certainly some aspects of the Singaporean system that I like, but it baffles me when libertarians talk about Singapore, because Singapore is a repressive dictatorship. And if you're going to model anything on Singapore, it shouldn't be because you're libertarian. So now let's turn back.
What if it actually-
The political system
wait,
is
wait,
not
slow down.
necessarily have to do with the
Slow
healthcare
down.
system.
One of us gets to jump
Yeah.
on him first, and I'm the moderator, okay? What if it actually worked? Are you saying if somebody has a bad political system, they can't come up with good ideas occasionally?
Okay, so this is a system based on high-level coerced savings, price controls.
That's not repressive, by the way.
Price controls on, it's coercive.
Is Social Security repressive? That's coerced savings.
Your usual objection to Social Security is that it's not a pay-as-you-go. It is today's workers supporting today's beneficiaries. Social Security is not coerced savings. And if it were coerced savings, you might prefer it to what it currently is.
So it's less coercive to say, I'm going to take taxes out of your dollars and give it back to you to spend yourself, as opposed to giving to somebody else, right?
Let's be clear about Singapore. There is limited freedom of speech. There is no freedom of assembly. There are price controls throughout the healthcare sector and capital investment controls, and there are high degrees of coerced savings that are reasonably regressive. If you like that, fine, but I can't see that it's a good model for a healthcare system. But I digress. Let me leave Singapore for a bit and now talk about sort of Avik's description of third parties and third parties to third parties. And by the way, if someone is a third party to me and someone else is a third party to that person, they are at most a third party to me. It's not arithmetic.
And your point is?
Avik gave you actually a very conventional description of high healthcare spending and what to do about it. He emphasized intermediation, agency costs, government intervention, and moral hazard. All of those things play a role, and I wouldn't argue against any of those as contributing factors. But let me offer you two things that are a little bit more different, let's say, from what you've heard before. One Avik's heard me talk about before, but it's a great teaching point, which is when we say the prices are screwed up, that means more than we pay too much. It means that all of the informational signals throughout our economy, our healthcare economy, that would tend to allow us to produce things at the lowest possible cost and allocate them well are also corrupted. And that is a massive problem. So pricing is a massive problem, and the classic presentation on this is Friedrich Hayek, 1945, The Use of Knowledge in Society, pointing out why market economies outperform centrally planned ones, and it's because prices convey information incredibly efficiently. So when we screw up on healthcare prices, we're doing more than just paying too much. We are screwing up in how we design the system. Second part, and this is my work these days, it's not just the price, it's the product. The things we call healthcare that we buy and sell are, for the most part, not intuitive products that don't demonstrably do anyone any good. And if, healthcare is the island and the rest is the mainland, it's an awfully big island. It's a sixth of our economy and, an eighth to a tenth of our job base, depending how you count it. When we spend that money, we're not just spending money at odd prices. We're spending it on stuff that no one in the mainland economy would ever think to buy, because we define our healthcare services according to professional traditions and prerogatives, according to the way we constructed prior programs like Medicare. And as a result, most of the things that you would pay for in healthcare do you no good whatsoever. A day in the hospital does you no good whatsoever. Most lab tests do you no good whatsoever. Most consultations do you no good whatsoever. What you need are services that do you good. And sometimes those are simple things, like you have a mysterious symptom and you want to know what the diagnosis is, and people would pay for that. Other times it's that you have an established problem and you want to see how you're doing with it, and people would pay for that. Other times you might, say, have an injury and you need a joint replaced, and you'll pay for that, but you're not going to pay separately for the hospital bed and the implant and the orthopedist services and the anesthesiologist and the radiologist. No, what you want to pay for is care for your hip with a decent warranty, 6 months, a year, 3 years, and you pay for that. And so we need not only get the prices right, we need to get the products right.
Okay.
I want to make one quick response and then question, which is on this issue of we utilize too much health care. So Uwe Reinhardt, who's a center-left health economist at Princeton, who writes a lot for the New York Times, had a great piece once where he talked about this called "It's the Price is Stupid," which is to say that it's not so much that we consume more healthcare services than other countries, it's that what we pay for those healthcare services is much higher. The average hospital stay in the United States is actually shorter than that in the OECD countries, but yet the cost of that hospital stay, the price of that hospital, whatever you want to call it, is much higher.
Okay. And time for a couple more brilliant questions. Brilliant question. Oh my, in the back.
Yes, sir. I was wondering where malpractice and tort reform fits into the equation. It seems to be like those are very big parts of the equation when you're looking at the cost of things, because you have to cover for the accidental incident that might occur.
So this is for the lawyers and the law students in the room. It is argued that there's a lot of medical, quote, treatment that's done to protect against medical malpractice lawsuits. Is that true?
So in the Journal of Health Affairs that came out this month, it's a special issue on medical malpractice, and I have 3 articles in the issue. And one of the articles is rather provocative with my friend, also MD/JD David Hyman, who teaches up at Illinois. And we actually backtrack on decades of public positions, and we say we'd be happy to pass national tort reform if that's what doctors would really like. But what's the twist? We want doctors to give something in return that we think the public would value much more, like let's move totally away from fee-for-service payment for services on an accelerated basis to different ways of paying for better products. Like, let's let people who aren't fully qualified physicians but are very capable deliver basic medical care to people. Like, let's be more accountable for our prices and for measurable quality of the things we do. And we call the piece Trading Malpractice for Health Reform. And that is a deal I would love to see. The fact of the matter, well established, is that medical malpractice liability is a very small contributor to any measure of healthcare costs, but a very large psychic burden on doctors. And if they claim that they really hate it so much, they should be able to offer something meaningful in return for getting rid of it.
There's a lot of debate as to how much medicine in this country in terms of the dollar value is defensive. The best studies that we have, which may not be accurate, the best studies we have estimate that it's about $50 billion a year. Doctors don't believe that. They think it's much higher. But if it's $50 billion a year, how much do we spend on emergency room care, which was the pretext for Obamacare? $50 billion a year, uncompensated emergency room care. So it's whether you think it's a bigger problem than $50 billion, let's say even it's $200 billion, we spend $3 trillion a year on health care in this country. So whatever the number is, it's a part of the solution. I think tort reform is a part of the solution. Will it be the magic bullet that solves all the healthcare problems? No, and I think that's where a lot of Republicans have been wrong. I think, for a long time, Republicans said, well, everything was fine with the healthcare system. Let's just get rid of, let's do tort reform, get rid of the malpractice lawyers and the ambulance chasers, and we'll be fine. And I would say that's not enough to solve the problems that we have.
And intuitively, it's $3 trillion. It's a sixth of the economy. It's a huge amount of employment. Where do you think its cost problems come from? Itself or outside forces?
Here in Texas, you have malpractice reform. It was passed. There's several rounds of it passed by the last couple of governors, and it hasn't actually, it doesn't appear to have had a discernible impact on health expenditures in Texas. It has had some impact on the supply of physicians because physicians have moved here from other states, but it hasn't had a dramatic impact on utilization and spending.
It hasn't had any. Let's be concrete. Texas tort reform dropped lawsuits to historically low levels, stabilized and reduced the insurance premiums for malpractice coverage that physicians pay, may have had a very small but possibly measurable marginal effect on the supply of physicians, and has done absolutely zero to healthcare costs.
I heard that 3,000 to 5,000 additional physicians moved to Texas because you're saying that data is
that data is wrong. The newest study that is not quite out yet supposedly documents that in certain high-risk specialties there's been a supply effect. I've never claimed there isn't a supply effect. I did a paper 10 years ago that was in JAMA with a very good health economist, Dan Kessler, who also co-authors with people that Avik has been citing, that said if you enact tort reform of the caps on damages variety, you will see over a long period of time about a 3% increase in the supply of physicians. It's not trivial, but it's not huge.
Next question. Yes, sir.
What are your thoughts on the current level of doctor salaries, and where do you see salaries going in the next 5 years?
This is one of the things that I often I talk to with doctors, because doctors feel very put upon, and they feel like the healthcare system is out to get them, and that if only we listened to doctors, we'd have a much better healthcare system than we do. My view is that doctors are massively overpaid. And I say that as someone who has many relatives who are physicians, who went to medical school. It's because prices, again, are too high, and physicians have benefited from the Medicare system, which basically was a blank check. It was an ATM for them from everybody else, from the taxpayers, where they could charge whatever they wanted for services, get paid whatever they want, and make lots of money. Now, that, of course, varies by specialty. But studies that isolate for the high cost of medical education in this country and a lot of other factors still show that physicians here make way more than physicians elsewhere. So I think any health reform that attempts to attack the cost problem will end up with doctors making less money, or most doctors making less money than they do today, and that's fine by me. And the AMA has been a big obstacle to reform, as you might expect, and that's actually one of the reasons why we'll probably never have single payer in this country. By the way, there are a lot of people on the right who fear that Obamacare is going to lead us to single payer. A lot of people on the left who hope it will. The reason we probably won't is because the way single payer cuts costs is through price controls and rationing. And the people who that $3 trillion in America is being spent upon are a pretty politically powerful group. And they're going to resist any sort of drastic measure along those lines. So I think the market-based approach has a better shot in the sense that if you have a more organic evolution towards competition, that competition will lead to innovation and efficiencies and lower prices.
Yeah, let's just clarify. So I agree on the innovation and competition pieces. I think the single payer conversation is more complicated than we have time for. But just to clarify on the AMA's position, because people should know this, it's actually been one of the sort of partisan challenges of the ACA is that although there's plenty of doctors who claim to dislike Obamacare and there are plenty of state medical societies that have opposed it, the American Medical Association supported the law from start to finish.
Because it didn't affect prices, didn't control costs.
For a variety of reasons.
So I think I understand, Avik, when you talk about the single payer system, I was wondering if you could expand of what a market-based system looks like and how you ensure that those that are currently on Medicaid are covered in that system.
There are a lot of ways to do it, but if we start with the principle I was mentioning earlier, which is that we'll have more you can have lower costs by dictating what the prices are and dictating who gets care and when, and controlling the supply. That's one approach. If you want to have a market-based system, you go the other direction. You say, put people more in control, in charge of their own health dollars. And if you do that, people will find ways to attract their business. So what do we need to do to move towards that system? First, create a system, facilitate a system where people are shopping for their own insurance plans, which for all the flaws with the Affordable Care Act that I've described, I think exchanges are a potentially constructive step in allowing for that process to emerge, in which people are shopping for plans and thereby finding the plan that best suits them. The next step is not just to shop for plans, and you have to have a real choice, which unfortunately Obamacare doesn't allow because it so restricts the types of plans that can be offered on the exchanges. But if you have a real choice of plans on the exchanges, people will naturally migrate to plans that have high deductibles that protect them against catastrophic financial risk, and health savings accounts, where again they're spending their own money on routine medical expenses. I mean, think about like car insurance. We don't expect our car insurance to pay for gas and our wiper fluid and our fuzzy dice. And yet, that's what we expect our health insurance to pay for. And so if you move to an actual insurance product where catastrophic bills are paid for, and therefore the premiums are pretty low because it's only a catastrophic product, you get to choose the plan, so insurers have to compete for your business, so that keeps prices low. And then for everything else, you have a health savings account, which you can subsidize for the poor. You can subsidize the premium for the poor so that access is not an issue. But give them a control of the dollar, just like we do with food stamps, right? We give them an EBT, and then they shop for it. We don't nationalize the grocery stores. We say, here's an EBT, go shop for the food that you want. You can do the same thing with health savings accounts. Subsidize a health savings account, let people shop for care, and you will find that modalities of care delivery will completely change because we have this fee-for-service system where a doctor gets paid for ordering a test or writing a prescription or whatever it is. Where we would go in a free market is you'd pay a monthly fee to a physician, $100 a month, say, or $80 a month, and then that physician would, the primary care physician would take care of you when you needed to. And you'd have to have more physicians, too, to do that model. And physician supply is a big part of the issue here. But generally speaking, if people are controlling their own health dollars, you're going to get a better outcome. And I think that, just to kind of give you an asterisk or something to look forward to, I'm actually in the process of publishing a fairly lengthy discussion of what a market-based reform would look like that doesn't repeal Obamacare, but that uses a deregulated version of the exchanges as a way of replacing Medicare and Medicaid, and thereby getting you to a point that approximates the Swiss system, which, while it's not as cost-efficient as Singapore, it does have a means-tested subsidy that it's on a sliding scale. So if you're poor, you get more subsidized. Middle class, you get a modest subsidy. You're upper middle class, you don't get anything. And it's all private insurers, and they have great access to physicians, technology, everything. They spend 40% of what we spend in terms of public spending on healthcare. And in terms of total national health expenditures as a percentage of GDP, it's pretty much within the mainstream of Western Europe. So I think that is actually, for all of Bill's complaints about the political system in Singapore and how repressive that is and how terrible that is and why Singapore is therefore not a model, I would disagree with him on that. But I will say that politically speaking, within the United States, Switzerland is actually a more politically realistic model for us. And Switzerland, last time I checked, was not a repressive dictatorship. So hopefully Bill has kinder things to say about Switzerland.
I have many Swiss friends, but I don't see them as a model for us either, and we could go into that in some detail. I think that's a grossly oversimplified description of a market-based system. And understand, I favor a market-based system.
So why don't you describe one that you would like?
Well, here's the problem, and Avik found himself getting into this difficulty as well, which is, if we had never granted a tax preference for fringe benefits of employment, including insurance, if we had never enacted the Medicaid program, if we had never put forward the Hill-Burton subsidies and subsidized medical education as part of the extensions of the GI Bill coming out of World War II, if we had never created Medicaid, if we had never allowed American corporations to accrue contingent liabilities for retiree health without putting them on the books until the early 90s. If we'd never done any of those things, what Avik describes is reasonable. But imagine how different that system would look from the system today.
You have to have a gradual transition.
But the gradual transition, I think, and we would, I suspect, agree on many of the details. I just don't want people to be misled by the ideologies here. The gradual, if you can agree on the objectives, the transition is going to be messy.
Oh, it's going to be messy.
It's not going to be just let people spend their own money, because you wouldn't have a clue what you're buying or whether the price is reasonable. And I've been beating the drum for price transparency for much longer than most people. Since the 90s, I've been beating the drum for comparable information about healthcare quality and for antitrust enforcement and for a host of other things. But this is not an area, and Avik will agree, where ideology is going to give you a process to follow.
I'm less pessimistic. I'm less pessimistic. If you look at economic history, every time you give people the choice, innovations flowers. And I think that if you give people more choice and more control of their own health dollars, you will see a lot of innovations in the delivery and design of healthcare and health insurance that we can't imagine because we're not the creative entrepreneurs who design
I
those
have to
products.
agree with Bill. It is going to be messy because there are people who benefit from the status quo who are going to fight like hell.
Absolutely.
In every place.
Change is hard.
That doesn't mean it shouldn't be done, and I think it should be done. Okay, we have time for another brilliant question.
Or we can. Sometimes it works at the end, if you don't mind, to take a few questions and then we'll answer whichever one we think, or put them all together somehow.
I like that idea.
It's a fair idea.
All
Let's
right.
do that.
I like that idea. We're going to take 4 questions. We have 4 hands up, and now we have 6 hands up. We're going to take 4 questions.
It's fine.
And we're going to see which one is worthy of answering.
Well,
Let's start with you.
So, the fundamental discussion we're having here is.
4 questions. That's it.
What should the government do? I get hung
Okay,
up
we got
on
that.
should or
Question
should.
number 1, what should the government do?
And so my question is.
Oh, wait, that
how
was your
do we
question.
know-
You have 2 questions?
My question is, how do we know what is the appropriate responsibility of the government to essentially step in and protect people from themselves?
Okay, so now, the first question, what should the government do? The second question is.
No, the first one wasn't my question.
We got it. Move on.
Yeah, okay, let's go. Next. Yeah.
Because I understand there's 40 million uninsured, and after this is implemented, they expect to be 30 million uninsured. And the people that remain uninsured will be those that are illegal immigrants or unable to afford health insurance. And so that the 10 million uninsured that
So
they
your
expect to
question
convert
is?
are those people that can afford to pay for health insurance and choose not to. So what is the point of converting people that pay for health insurance who choose not to because
You guys get that one?
benefit from it?
That's good, because I didn't. Okay, next.
It seems like the latest battle cry amongst the supporters of the ACA is this Kaiser study that said that even if not enough young people sign up for the ICA, there won't be an adverse selection spiral. I wanted to get your guys' comments on
I like that question. I can understand it, yes.
How does a high deductible insurance plan keep a boy from dying from a brain infection caused by a tooth abscess?
Maybe we can get a couple more from the end here. So there was a couple guys who had their hands up over here.
I'm going to continue. I'm going to decided to continue because there are people who are twitching over there. Okay, next twitcher. Okay, yes.
Me? Oh.
Yeah.
There's been a lot of arguments around decreasing costs in the healthcare system by increasing access to preventative care. And you kind of talked a little bit around it, but didn't really focus in on it. And I don't know if that's fuzzy dice. But
What's your question?
But comment more.
What's your question?
Elaborate on that.
You got it?
Will it help?
All right, fine. Next, sir.
There's a lot of talk about electronic records. I'm just curious how that plays in, if that can affect costs and outcomes.
All right, and then last question. I saw a hand back there. Two more. Okay, go ahead, sir.
So you had mentioned that doctors are paid too much. How do you propose that should be lowered? And is there a concern that perhaps, especially in specialties, would that lower the supply of people who would enter the medical profession, given that some people who do enter the medical profession are because of the high income that it provides, and that there is a substantial cost for medical education?
Gotcha. And the final question, last but not least.
Arguably the greatest transfer of wealth and the most socialist program in the history of the world. How do you guys feel are the aspects around having young people essentially be forced to pay for health insurance for
We're
others?
talking about Social Security, Medicare, or ACA?
The ACA.
All right.
Okay.
Gentlemen?
Yeah. So there were a bunch of questions just around the whole idea of what's the proper role of government? Who should we try to help? How would a market-oriented system help the poor, et cetera, et cetera? So let me start with that and just say that the reason why an HSA plus a high deductible plan would be helpful to a guy like Diamante Driver is that instead of the Medicaid program, which basically a lot of dentists don't take, and therefore he couldn't get access to a dentist, if you're a cash-paying patient, most doctors will tell you, if you pay cash, I'll see you, because then I don't have to fill out 10 different forms to get paid. And that hassle factor alone is a big inhibitor, let alone the actual reimbursement rate. So you're willing as a doctor often to accept a lower price than what insurers will pay if there's no paperwork involved, because the paperwork, the compliance has an economic cost. So the access to preventive care and primary care will be much better, which leads to efficiencies down the road because you're not having to get brain surgery for a tooth abscess that's infected your brain. So in terms of electronic medical records, this is a good one that relates to all this too. I checked into my hotel last night to be here with you today. They knew a lot about me. They knew how many times I'd stayed in their hotel or in their hotel chain before, various things about what newspaper I preferred. There was no federal law that required a Starwood Hotel Group to have that information, but they had it anyway. Why is that? It's because they have an incentive to provide good customer service, because that might bring me back. The reason why that isn't true in our medical system is because the patient is not the consumer, because the patient isn't paying for the care. In any system where, again, the consumer is the one who pays, the patient is the one who pays, then there's a lot more customer service, including things like emergency medical records, because if you as a hospital or a doctor don't do a good job caring for that patient, making sure you avoid medical errors, and you get a bad reputation in that regard, people won't see you anymore. You'll have reputational harm, you'll have litigation. So we're very far removed from that system, and you might have to have legal action to pry it open with things like price transparency and quality factors and things like that. And we do that to some degree with hospitals. There's a star rating program in Medicare that revolves around things like readmissions rates. So if someone gets in the hospital for an infection, if they come back a month later, you get penalized. But that's a very bureaucratic, centrally planned approach. That's one way to do it. A better way, an ideal way to do it would be to give hospitals the economic incentive to actually avoid medical errors because patients will give them more business as a result. Unfortunately, we're far removed from that system. But I think with EMR, electronic medical records, things like that, it's worth thinking about that. Why is it that every other industry has electronic records and not healthcare?
Okay, I want to talk about socialists in two ways, and then I want to talk about accounting to close. So first way, socialists. There were some questions about who's covered under the ACA, who's paying for it. So and how much of this is massive wealth transfers and creeping or crept socialism. So most of the people who are the expansion population right now are actually people who have some fairly serious health conditions and had trouble accessing coverage in private markets, and they voluntarily like the deal of community rating or small variations of community rating, and the fact that they have to be accepted and renewed. Where is there a massive expansion of government in the ACA? In my view, only in one place, which is the Medicaid expansion, which the Supreme Court then turned into an option, and largely for political reasons rather than true self-interest. About half the states have stayed on the sidelines of Medicaid. Well, that Medicaid expansion population is a very valuable population for the future of our country, because if you think about what do states confront right now without the federal support that would be part of this uniform expansion, every state legislator I have ever met or could imagine basically walks into work wondering if they're going to cut health care that day or cut education. And that's a very foolish and tragic choice to have as a society, because when you invest in education and health, you are investing in your future. And yet these two stand in sharp opposition to each other on the plate of every legislator in every state pretty much every day. So who's covered? Well, who's covered now are the people who were sick and therefore uninsurable. The people who would be covered if the states accepted the Medicaid expansion are people who are largely quite healthy and either employed or employable, and the investment in them is an investment in the future. So where are the real socialists? Well, the real socialists, actually, this is point 2 on socialists, are Americans' doctors. And so Avik said he goes into the hotel and the Starwood Group doesn't have to have a government mandated subsidy for its electronic record to say who he is and what he might want. And doctors do. Well, why do doctors need that? Doctors need that because doctors are the most undercapitalized businesses in the country. Doctors have always relied on the kindness of strangers for all of their investments in everything. And they really haven't been set up to make perfectly rational competitive investments in serving their customers. So that's my second point on socialism. What has been the most socialist act of the medical profession over the years? It's the fact that we, throughout the country, allow doctors in private offices to use hospital facilities to treat their patients at absolutely no cost to them and with no sense that they need to invest in the future of the hospital. They just get to use it and bill for treating their patient while their patient's there. Incredibly socialist basis for our healthcare system. Last point here, I get to, you could teach con law, I can teach accounting for a moment. And it's the question on prevention, and it goes back to some of the other questions that were asked earlier about behavior change and Avik's answers on the cost of behavior change. Let me tell you 2 things about accounting for prevention and accounting for changes in healthful or unhealthful behaviors. One is costs and benefits take place at very different times. And so, as you've all learned, discount rates matter. And often when you hear a number thrown out, oh, it saves money to do this, or it costs money to do that, it really has nothing to do with the merits of what you're debating. It has to do with the discount rate you chose for the calculation, and that's just a good caution. The other is, what do you count in and what do you count out? So if the notion is, does preventive healthcare save on long-term healthcare costs with plausible discount rates? Probably not. If you say, does preventive health care make people feel better off and contribute to their communities and contribute to their economies, chances are it helps. So your accounting is your discounting and also what you consider worth counting and over what time horizon.
So I'm going to end with just 3 observations, and then we'll thank our panelists who've done an absolutely excellent job. I've been blown away. With the last one. The last one was going to be what you just said was going to be the last thing I was going to say. Now it's going to be the first. John Mackey is the founder and CEO of Whole Foods. He's a libertarian, and they self-insure. They do not have an insurance company. They pay for the health care of their employees out of their own revenues. And he talks about a few years ago, one of his people came up to him and said that she had a problem with diabetes and bad things were happening to her. And it caused them to think about, they were just providing reimbursement for medical expenses with their own internal self-insured program. They were doing nothing to impact behaviors. And so they created a wellness program, which He's a libertarian. They strongly encouraged all their employees to participate in and got a very high participation rate. And he said within 2 years after they created the internal wellness program, they saw the amount of money they were spending for insurance, for medical expenses going down. And since they are self-insuring, they know how much they're spending because it comes straight to the bottom line. So there's a lot of evidence that if you combine wellness and encouragement, it costs less. Second, I'm in Germany a few years ago, and there's a big debate about whether or not in the German healthcare system there will be copays. And back then they were talking about a copay of 10 euros for each visit. And the people who were screaming the hardest against that were senior citizens who were going to doctors and nurses because they were lonely and they wanted to talk to somebody, and they said, but if we have to pay 10 euros for that, we're not going to go. And they were saying the impact of charging 10 euros as a copay would have substantial reduction in the amount of on the cost, because people were going because they were lonely, would say, yeah, I may be lonely, but not for 10 euros. And then finally it gets to the issue of transparency. My wife is working for a company that offers a health savings account approach. As we had a debate, does she go on my policy, which is the standard socialized policy for the state of Texas, right? Or we do the health savings account. And she said, all my friends say this is better. So I said, try it. And then she got her first bill. Because nothing's hidden. If she's on the UT program, you pay a copay of $30, there's some deductible, but for hers, into maybe the first $4,000 or $5,000, she pays 100%. She said, holy crap, I didn't know how much it costs. And so at the end of the day, what I look at is, if we have transparency in how much it costs for us to get medical care, if everybody knows how much this system is actually costing every time we go in, that will create the foundation for some real meaningful change. As long as prices are hidden, it's really hard for people to understand what's really going on. And you would be amazed at how much it actually costs if you go to an emergency room and say, I'm not feeling good, doc, could you look at me? Typically it's like $1,500 to $2,000 to $2,500, depending on where you go. Be amazed. And so we'll end with this. There has been a rumor, and that rumor is Walmart's going to get into the health care business, and that they're going to put 24-hour clinics in every one of their Walmarts and have value pricing. True or false?
I hope it's true. Walmart historically has not taken that approach, whereas CVS has Minute Clinic, HEB has a clinic chain, and several of the other retailers have transparently priced basic services, all of which I think is wonderful. Walmart has tried very hard to develop relationships within its store communities, and instead has entrusted the in-store clinics to a local hospital or established provider, not taking advantage of its transparency and not taking advantage of its supply chain management. So I'm hoping that maybe Walmart, if that's the rumor, is going to go away from that rather deferential approach and actually get aggressive. I'd like to see it.
That is, I've heard that as well. I would say that in general, the delivery of healthcare in America has been very resistant to entrepreneurship because of all the ways in which the government distorts it. The one thing I will say is that to the degree that a lot of the people who are getting coverage through Obamacare are choosing high deductible plans with $5,000, $6,000 deductibles, it may be that for all the flaws in the law, if it ends up that the law actually drives more people to these high deductible plans because they're cheaper than the lower deductible plans on the exchanges, that it will help and drive more people to plans where they're consuming care for themselves and therefore have an incentive to shop for value. This is what we're seeing in the employer-sponsored market, where a lot of large employers, including Walgreens, for example, are moving to what are called private exchanges, where they give you $5,000. They say, here are the 12 plans on the menu. Pick one. If you want to pick a more expensive one, you have to cover the difference. And in that way, people are choosing and migrating voluntarily, again, to plans with higher deductibles and HSAs. And that's why I think I'm more optimistic about the success of market-based reform, because if you give people the choice and say, you're going to save money if you choose this plan versus this plan, it's up to you. You can decide what you want to do. A lot of people will choose the high deductible HSA approach because it's more cost efficient. And if you give them the choice, it's going to be a lot less controversial than if you dictate it to them from above.
Okay. Ladies and gentlemen, we've had one of the most intelligent, restrained, but also informative conversations about healthcare reform. Let's give our panelists a hand. Thank you very much. And on behalf of the Adam Smith Society, I'm glad you guys have come. And we had an event a year ago. We had 18 people in the room, or 20 people in the room. We're going to continue to have events. I'm saying we're because I'm the faculty advisor for Adam Smith. Let your friends know this is what we want to do. Put real facts, real numbers behind issues that are very important and help people get a better sense of why we can make things better. Thanks a lot for coming.